All right, well, thank you for inviting me to come. And Dr. Chapman actually asked me to talk about multidisciplinary pain care comparing inpatient and outpatient. And at this point in time, there's, I think, one inpatient program left, which is at the VA in Florida. And so I'm going to really talk about more comparing multidisciplinary care that's done under one roof with multiple providers in one place versus trying to piece together an outpatient program. So my goals are to kind of briefly describe, first, just a paradigm for thinking about pain as something beyond nociceptive input, because that's really important for understanding how you can actually rehabilitate somebody who has pain that we can't get rid of. I'm going to talk briefly about what multidisciplinary care is and just go over what actually happens for the patients when they're there. Take a look at the research that supports the effectiveness of this, and then take a look at how you get benefit from doing this all in one place versus trying to put it together. So for pain perception, one of the things to think about is that pain is not just our nociceptive input and really exists as something that happens in the brain. It occurs because of a very complex interaction between peripheral inputs, modulatory processes that happen in the spinal cord and also in the brain. We have an endogenous pain modulatory system that has both facilitatory and inhibitory factors. And so what's going on in the brain to either facilitate or inhibit pain is very important for how people function. And pain modulation occurs at just all levels of the nervous system. One of the ways that we think about pain when you think about rehab is to understand that pain is also sometimes thought of as a behavior. And for the person experiencing it, it is an experience as opposed to a thing. So when we think about pain behavior, those are the things that people do that let other people know that they're hurting. And pain behavior can be how we're moving, our facial expressions, also what people verbalize. Those are all pain behaviors. So as the provider, you can tell the person's in pain because of what they're doing or what they're saying, but you still can't actually measure their pain in any, what we would call objective way. Pain behaviors also really affect the person who is doing those behaviors. They are not only the way that the person expresses to other people that they're hurting, but it's how they express in some ways to themselves. And when people are engaged in pain behaviors, that often actually ramps up the pain that they experience. And when they change those behaviors so they're doing more wellness kinds of behaviors, they often experience less pain, even though what's going on in their body has not necessarily changed. Pain is also an experience, and it is an experience that is created by the brain. It comes in part from nociceptive input that we get from the body, but that input has to be interpreted, and the brain has to decide, how important is this? Is this dangerous? What does this mean in my life? If somebody who gets injured at work and they bend over, they pick something up and they get a sharp pain in their back, what's going through their head, maybe not even consciously, is like, oh my goodness, what does this mean to my livelihood? Am I going to be able to continue to do this job? I have all these debts. I have, a family at home I'm supporting. I can't stand my employer. All of those things are going on in that person's brain, and they all come together to create that person's experience of that pain and to create the brain's attention to what's going on and the decision that's made about, is this dangerous or not? And so that notion's very important for thinking about how do you help people to move forward when they have persistent pain. So multidisciplinary pain care for the person with chronic pain requires both the provider and the patient to really look at what's going on from a different point of view. Most people come to the doctor with pain and they expect to get an MRI scan like we've seen, and somebody to say, oh, this is what's wrong, and you point up on the scan, say, this is the problem, and I'm going to inject it, or I'm going to do surgery, and you're going to be better. And we all know that we have lots and lots of people for whom we can't actually come up with a diagnosis. We don't have a clear identification of this particular part in the body is generating your pain, and we can take it out or fix it or change it in some way. So as providers, we have to get to a place where we're comfortable saying, you know, we've looked at everything we can look at. We feel like we've eliminated everything that might be dangerous or life-threatening, and be comfortable with saying, okay, there's no more searching that needs to be done. And then we also need to educate our patients about that and help them come to understand that at some point it no longer makes sense to keep looking for that pain generator. And at that point, what multidisciplinary care does is really tries to focus on what's the functional impairment of the person's problem. How does that reflect in the amount of disability that they have? And then how do the person's beliefs perpetuate that situation? Because what multidisciplinary pain care really helps with is promoting people's functional improvement and diminishing their disability and improving their ability to live with whatever structural problem that they have. So what happens in multidisciplinary care is that people come for treatment that typically lasts 4 to 8 hours a day. When you look at the research, there's been a variety of things. I would say on average, most programs run about 6 hours a day. Treatment is daily, so the person is coming at 9 in the morning, they're staying till 4 in the afternoon, Monday through Friday. So they're there all day, every day. Exercise is a very important part of the whole process, and it targets the person's functional impairments, their general conditioning, and also looks at body mechanics, teaching them how to move in ways that are safe for their bodies. Cognitive behavioral therapy and psychological counseling is a really important part of what happens in these programs. And once again, it's different from program to program, but in general, there's education and group sessions as well as individual sessions. The manner in which we teach people to begin to get reactivated is something called quota-based reactivation, which I'll talk about a little bit more. It's also a team approach, so there are multiple providers. So there's physical therapists, occupational therapists, vocational counselors, psychologists, and physicians all working together. And the goal is to address many facets of the patient's problem. So looking at their physical functioning, but also the psychosocial consequences of having chronic pain. And so the exercise portion of the program is based on something called quota-based reactivation. And the key to this is helping people get so that they can start to increase what they're doing and not be limited by their pain. So most people come into a program like this where their prior behavioral pattern has been one of doing as much activity as they felt they could do in any one day until they hurt too much to do more. And sometimes they'll have a good day and they'll do lots and lots of stuff, and then they'll be miserable the next day and they'll go, okay, that was a bad idea, I better not ever do that again. Most people then go through this kind of, I do a lot, then they do a little, and it's very hard for them to actually ever make any progress. So this quota-based approach basically has the person come in, you test their baseline, you figure out what can they do that they can actually be successful at now, and that they could do day after day after day without flaring up symptoms. And it may be actually a lot less than they might do on a good day, but it's a level that we want to be sustainable day after day. We then ask the person to do a little bit more each day, and the goal is that you have a set amount of activity that just progresses on a very gradual basis, and the patient is not allowed to do more if they feel really great, and importantly, they're not allowed to do less if they feel bad. And you're just going to be encouraging them, you did this yesterday, you were successful at it, you can do this a little bit more today. And our big goal is to take pain away as the thing that's guiding what the person does, so that it's no longer, I hurt so I don't do it. It's like, I know I can do this. I did it yesterday. It's safe for me. So it really changes the way the person's thinking about what they're doing. And sometimes people have to start at really, really low levels. So as the cartoon says, if you haven't exercised in a while, you might need to stretch and warm up before you stretch and warm up. So it's okay to start somebody out at a pretty low functional level. The other thing that we do, so with the exercise, it's this quota-based approach. The other, I think, really important thing that happens in these multidisciplinary programs is what I call neuroscience education. So it's a process of teaching the patient that pain is an experience, and it is an experience that's created in the brain. And there's actually been several research studies looking at the effect of actually just educating people about how the nervous system works, how the brain works, and what the nature of pain actually is, showing that you can have a really positive effect on both people's reported pain, on their disability. It's very helpful for decreasing what's called catastrophization, where people just, when they hurt, they think it's a disaster and they're never going to get better and it's always going to be this way. And people's physical performance improves as well. So the education part of it is really important, and I think what has sort of changed over the last several years is people are starting to recognize that you can actually teach patients a lot about the physiology of the nervous system, and you can treat them as intelligent people who can learn and understand, and they will become much more engaged in what they're doing, and it really helps them to feel better. Does multidisciplinary care work? The answer is yes. This is an approach that's been around for many, many years. It was pioneered at the University of Washington Medical Center. Wilbur Fordyce was a psychologist, and his sort of initial innovation was to treat pain as a behavior. And he treated patients with chronic pain and very entrenched disability. Their program was originally an inpatient program. And I once went to a talk that he gave, and he talked about how one of the strategies they did early on was they had a patient who'd come in and who had rheumatoid arthritis. So they had a significant biologic problem that was causing their pain, but they'd become completely disabled and dysfunctional, and all they talked about was their pain. And so the whole team would come in on morning rounds, and the patient would start talking, and they had agreed that every time the patient talked about his pain, they would look out the window. And then when he would talk about something else, they would look back at him. And so they just sort of, that was one of their sort of first attempts at how do we kind of just encourage this person to pay attention to something else, and the patient started to talk about other things. So his approach really was pain is a behavior, it's a learned behavior, and we can use basically operant conditioning to change people's behaviors. And so he did a study in 1973 and demonstrated that people had less pain reports, they had less pain behaviors, their wellness behaviors increased, and their function improved. They also walked more, they had less medication use. Since that study in 1973, there have been many, many, many studies over the last 40 or more years, and the outcomes from those studies, which probably cover, certainly at least 3,000 patients, probably closer to 4,000 or 5,000 patients, show that pain is less, medication use goes down, healthcare utilization goes down, people's function improves, they have fewer fear avoidance beliefs, they go back to work more quickly, and the studies that have tried to look at long-term outcomes show that at a year you can actually sustain these benefits. And there's a lot of studies in the worker compensation setting that look at people, do they actually go back to work? And there are many studies that show that you actually get significant improvement in return to work. And I wanted to just point out the last study, which was in spine in 2014. This is a group, it was a prospective study, looking at people who had had surgery. And the numbers that are up there are comparing this group of people that had had surgery who went through a multidisciplinary program to kind of outcomes reported in the literature. So they did not have like a control group that didn't go to rehab. But they had a large cohort of patients, and many of them had had fusion surgeries. I think a little more than half had had fusion. A few more of them had had surgery to just decompress the lumbar spine. And they put all of those people into a functional restoration program after their surgery. And what they found is that for those people who went through, whether they'd had the fusion surgery or the decompressive surgery, or the control group, which was a group of patients who'd not had surgery, the return to work rates were all pretty equivalent. About 85% of those people went back to work. And if you look at in the literature, when people have had fusion, maybe a third of them go back to work after that without rehab. And the point in this article is really that you don't have to do just surgery or just rehab, that you can actually do both things in a continuum of care. And for those patients who are really at risk to remain disabled, doing the multidisciplinary pain care and functional restoration can give you much better outcomes. So then the question is, who needs this kind of care? And it's really people who have what I call barriers to recovery. And this is just a list of many of the things that actually keep people disabled and prevent them from getting better. A person doesn't have to have all of these things to necessarily qualify for multidisciplinary care, but these are all things that can be a clue when you're evaluating somebody that multidisciplinary care may be the thing that will be helpful to them. And there was one study done trying to look at how can you actually choose and tease out which patient's going to do better. And in this study, they used a number of physical exam findings plus questionnaires looking at things like depression and pain catastrophizing and self-efficacy. And they divided their clients into the research subjects into three groups. People for whom they thought there was a good prognosis, they're likely to get better no matter what. People with sort of a medium prognosis, and then this group that they said this group has a really poor prognosis based on our assessment. And what they found was that the people with a poor prognosis, when you put them into a full multidisciplinary setting, you got a much higher return to work rate as compared to just doing individual visits with the doctor and individual therapy sessions. So finally, I want to finish with talking about what do you get from doing this all under one roof. So this multidisciplinary program that's many hours a day in one place with all these different providers versus trying to piece it together where the person goes to the psychologist once a week, then they head to the physical therapist down the road, and they're off to the vocational counselor somewhere else, where the person's kind of traveling all over. And so the key is that the under one roof is really the ideal way to deal with all those barriers to disability. So it's the way to kind of get through those barriers and to actually address them. So one of the things is that you've got the process of taking people out of their usual space. So when people become disabled, they become very much entrenched in what they're doing. Their family ends up kind of supporting them. The person says they hurt. The family member says, "Oh, go sit down." There are also many things in their home that just kind of cue them to keep doing whatever behaviors they have been doing. And so we're trying to get them out of the recliner and away from their television set. And so by having it all in one place, the person has somewhere to go and a different atmosphere to be in. It also provides tremendous social support. I think social isolation is one of the things that we sometimes don't really recognize in these patients. They were at work and now they're not at work. They sit at home, they don't feel good, they can't go out and do what they usually did with their friends. And so they become very, very socially isolated. And when they come into that group setting all under one roof, they get the support of the whole team that's there every day, but there are also other patients there who have similar kinds of problems, and they see that other people are actually succeeding and making change, and that's very helpful for supporting them and trying to do something that's really difficult. The education that I talked about earlier is also something that you can't just give the person kind of one little 10-minute talk in your exam room. It's a really, really different way of thinking about how your body works and thinking about how your brain works. And so people need sort of continuous education. And when you do this all under one roof, you've got a lot of different ways you can do that education. So there are formal lectures that the patients go to. The patients get individual sessions with the medical personnel and the psychology personnel. And then the physical and occupational therapists in this setting can provide basically continuous education in the context of the activity that people are doing. So when the patient says, "I can't do this, it hurts," the physical therapist can be right there to say, how are you, to look at, okay, your mechanics are good, how you're moving is good, and to be able to sort of talk about why what's going on might be painful to them, and just keep bringing it back to that notion that pain is this experience in your brain. And it's overall just much easier to do that when you've got that whole team there. It also creates a kind of work-like environment. So once again, people, they were at work, now they're out of work, they get, any of you have been on vacation, you go on vacation, you get used to being on vacation. It's nice to be on vacation, at least for a while. And when you go back to work, it's kind of hard. You're tired at first. And for these people, they've often been out of work for so long, they just really don't even know how to keep to a schedule. They don't sleep regularly, they don't get up at the same time of day. And so having this all in one place over the course of the day helps just to create that sort of normal behavioral approach. It also helps people to learn how to pace their activities so that they can actually be active throughout the day and hopefully then have something left over for what they do at home. The psychological part of treatment is also much more diffused through the entire program than you would get when you try and do this piece together. The psychologists, of course, give educational sessions. So at RIW, they do 3 group classes a week and go over things like how to, various kinds of pain management and coping strategies. They look at sleep, they look at depression, but they also meet with the patients individually, usually at least weekly, but more frequently for patients who are in need of that. The psychologist can go into the gym and work with the patient in the gym to kind of take some of those psychological strategies and actually help the person apply them right in the moment of trying to do activity. The physical and occupational therapists over time have become great psychologists really in their own right in terms of helping people with applying those psychological strategies to their activity. And the other benefit of all of us being in one place is that the physician is always available. And so when somebody, pulls something or they get a new pain or something happens and they get really fearful and frightened, they can see someone on the medical team right away who can examine them, reassure them, and so you don't lose any time in treatment because you're not having to stop and say, okay, go to your doctor, let's make sure it's okay, and come back. So it just helps keep people in the process and moving forward the whole time. Finally, the last really big benefit is you've got all your providers on the same page. So you have the team giving the same message to the patient. They get barraged from many, many places. And one of the things that always makes me kind of smile is that a patient will come in and complain about something, and I'll give them an explanation or tell them what I think about it, and they'll go, oh, that's what so-and-so said, and that's what so-and-so said. And so even though the team members, we haven't spoken to each other, we are all on the same page so that we are constantly giving the same message to the patient. So in summary, multidisciplinary care provides a really effective way to address the multiple complexities that occur with chronic pain and really helps address a lot of the psychosocial consequences of it. And for some patients, it's really the only way that they're going to diminish their disability. And I put this picture up because obviously most of our clients are not in wheelchairs, but what this shows is you've got somebody in a wheelchair who's moving forward anyway, and that's really what's true for these patients, which is that they've got often very significant musculoskeletal problems, and yet they can actually learn to move forward and really get beyond their disability despite whatever their physical limitations actually are. Thank you.